Words matter. You've got to pay attention to how you describe whatever you're going through or what you think somebody else is going through. So words matter, number one. Number two, it's a reflection of knowledge. When people don't address the problem the way the problem is, it tells me that they have no clue what they're talking about. So when clinicians use the word failure, when surgeons use the word failure, I'm like, okay, just because you can cut doesn't mean you know the disease. It's the same way, just because you can prescribe a medication doesn't mean you really fully understand the disease. So if somebody really understands the chronic, relapsing, progressive nature, right? Every word matters. Chronic, relapsing, progressive nature of the disease of obesity, they're not going to use the word failure. It cannot fit in the vocabulary.
Welcome to the BariNation Podcast, a production of the BariNation Foundation,
where we fight obesity by living our pillars: movement, mindset, metabolic wellness, and community.
4 pillars, 1 mission. We're so glad you're here.
Today's episode is brought to you in part by Johnson & Johnson. We are so thankful for their gift to the BariNation Foundation because it allows us to live our mission to bring education and resources together for people who need it. Thank you, J&J, for your support. Hi, friends. Some honesty before we start. If you have regained weight after a diet or bariatric surgery or GLP-1, yes, it can happen on a GLP-1, and you have been quietly blaming yourself, this episode is about to change the shame that you are feeling. I'm sitting down with Dr. Majid, a bariatric surgeon who just published groundbreaking research on weight regain. And here's the kicker. She reviewed 119 medical studies, and almost half of them never even defined what regain means. The reported rates range from 9 to 91%. 91%. No wonder we're all feeling confused and alone. By the end of this conversation, you'll stop calling it regain. You'll know why it happens naturally for all humans, not just you. You'll know exactly when a few pounds actually matter, and you'll have a plan you can start with today. She also tells us why the word failure is now officially banned from this field, and honestly, I am very excited about that. So drop a comment right now, whether you're watching or listening, and tell us your biggest question, your worry, or your fear about regain. And when you're done watching or listening, come right back here and tell us what your biggest takeaway was, because we read each and every one. All right, friends, let's dive in. Hi, friends. Welcome back to the BariNation Podcast. Today's episode will hopefully change your life. If you are treating the disease of obesity, either surgical or medications or a combination of them, weight recurrence, or what you're probably calling regain, is not only common, but to be expected. And the expert that we are talking with today, Dr. Majid, just published a paper. I'm holding this up if you can see it, and it's highlighted like I'm back in college, on why weight recurrence is so common and how it can be prevented if we engage with clinical care throughout the treatment continuum. So Dr. Majid, before we dive in, will you please introduce yourself to the people watching and listening?
Thank you, April. And again, very grateful for the invitation. This is fantastic. A topic that is very important. I consider it the elephant in the room that everybody tries to avoid, but so critical to address. So I'm really grateful that you've given this priority. My name is Saniea Majid. I'm a bariatric surgeon, obesity medicine specialist. I've had the privilege to start 3 separate bariatric and metabolic programs. The latest one is Weight Loss and Wellness Center in New Jersey. And every single one of them has been a comprehensive, truly multidisciplinary program. I've also been the past president of New Jersey State Chapter of ASMBS, which is American Society of Metabolic and Bariatric Surgery. I'm currently towards the tail end of finishing up my presidency of the ASMBS Foundation that functions as TRIO, Treatment, Research, and Education to End Obesity. And I sit on the board of directors of ASMBS. So really, really excited to be here.
When you and I first recorded, maybe a year and a half ago, you had said after we were done recording that you were doing this research study on weight recurrence. And at that time, I said, as soon as that is published, will you come back and join us? Because you and I both know this is the thing that every person who's treating the disease of obesity thinks about and worries about. And the research that you conducted is really groundbreaking and also a little bit alarming that there are so many holes when it comes to kind of like definitively diagnosing weight recurrence, right? Or regain. So our goal for this conversation, friends, is that by the end of this, you will not call regain. You will call it weight recurrence, and you will have a plan that you can implement immediately to help you start tackling this if that is what you are experiencing. So that's the goal. We know it's a lofty one, but we have the best person on the planet to talk us through this. So I'd like to just kind of get right in. Dr. Majid, you and I both know that a lot of times patients will not go back for follow-up care. What is the thing that is
Yeah,
driving that?
fantastic question. I think in 16 years of me exclusively focusing on obesity as a disease and taking care of these patients, what I've learned through my patients themselves is they don't fully understand that obesity is a chronic disease, which means it's a lifelong disease.
Mm-hmm.
And yes, getting surgery is extremely important, but it does not stop there. You have to continuously check in with your clinical care team, with your surgeon and his or her team, and that has to be for life. So I think that could be one reason why people don't come back, because they don't really truly believe or understand that obesity is a lifelong disease. Number two, when patients are losing weight, and we call it the honeymoon phase, and everything looks great, they're like, oh, well, I'm doing fine. I don't need to go back. There's plenty of things that everybody in today's world can fill up their day with, right? So they don't do that. And when they start experiencing weight recurrence, like most of human beings do, we try to justify, oh, is it the switch in the job? Is it the bad relationship? Is it the stress? Is it the wedding? Whatever it may be in life, you're like, maybe it's just that. This will get better. So there's a phase of denial. And then when you realize that, wait, the wedding has come and gone, but the weight recurrence is still with you, then there is a huge element of shame. I can't believe I let this happen to myself. I did surgery. How am I going to go back and face my surgeon? What will he or she say? Patients judge themselves. And therefore, that feeling of shame holds them back. So over the years, these are the three major things that I have learned from my patients that are stopping them from not coming back.
Yeah. It's the number one thing that we hear and see and really talk about in the BariNation community, right? Besides people who are really in that pre-op stage. Yeah, life tends to be really great right after surgery. And then all of a sudden it stops behaving the same way, right? We hit that stall, we hit that plateau, or we start to experience a little bit of regain. And that shame drives people into silence and isolation. And that is the exact opposite of what we need to do to continue to treat this disease. Because just as like what you said, this is lifelong and chronic, and surgery or medication does not cure the disease. It treats it, which is powerful. But if we're not continuing to go in for care, that disease is going to start overrunning our life again. And then it's going to feel like it's out of control.
Absolutely. And the problem with weight recurrence after you've gotten treatment, what I've observed from my patients, they are extremely hard on themselves. Because once they come in with that, let's say you're at a certain weight and you're experiencing the medical problems at a certain weight, you get the treatment. Life happens. We just went through all of that. And now you are 5 years later, 10 years later, back to that weight. It's not just about the weight and the medical comorbidities. It's like, I can't believe I failed that treatment. I got the surgery, I got the help, and I'm back where I started.
Yes.
That weighs so heavily
Yes.
that patients just torture themselves and deprive themselves of well-needed care because of that. And that's exactly what they should not be doing. When they're experiencing weight
Yes.
recurrence is when they need the most help. So isolation is what they end up doing, and isolation
Yes.
only makes it worse.
Yep, it only makes, and I can say this from personal experience, right? Weight recurrence and isolation is the worst thing. And the only reason that I am where I am today is because as soon as I started to experience weight recurrence, I had a community that I could turn to, and I could say the scary things, and I could ask the questions, and I could find that little oomph of inspiration or motivation to make that phone call to continue right with my care. But if you're isolated, you're just thinking this is 100% me. I'm a failure. I mess things up, which is not true at all, right? This is your biology and your body fighting a disease that has no cure. It's just a sign that more treatment is needed.
Absolutely, 100%. And in April, this is what I saw my patients suffer. You could see it in their eyes, right? Because they're still like trying to package all of that when they show up. And it's brave for them to ask for help again. And I could see it, and I'm like, we need to talk about this. So, which is what prompted the whole,
Yes.
6-7 years of research and everything else that you have in front of you, in your hands.
Oh, yeah. Yep. And friends, this research study is going to be linked in our show notes down below. So either if you're watching or you're listening, go click this link, download this document, and highlight it like I do, because it's actually a very hopeful document, because you very clearly lay out the recommendations and the researchers' recommendations for how we can, as patients and practitioners, treat weight recurrence in a much more kind and timely fashion. Because like you said, this is something that could potentially be avoided, right? It doesn't have to happen. So one of the numbers that stood out to me immediately, well, there was two. In your report, you said weight recurrence is not uncommon, with reported rates ranging from 9 to 91%, depending on the definition used. Why is there such a huge gap?
So this is the statistic that made me, like, fired me up. I'm like, if the variation is this huge, we, the medical community, must do something about it. I myself was not aware of how all the clinicians, the surgeons that are publishing in peer-reviewed journals. I'm going to take a step back, and I want to make sure that I'm not assuming and taking for granted that everybody in the audience understands the medical literature, right? What we publish in our medical literature is not like an article in a magazine. That needs to be vetted and studied and researched, and that can take months, if not years. Every single sentence needs to be accurate. We can't make anything up. And we have to back every statement with real, legitimate references. It can't be, that's what Majid thinks, right? It has to be, my source of data is this, and this. And it has to be published. If you'll see in the paper, the last few pages are just a long list of references. And so that you can go and look those references up. Wait a minute, she said 9 to 91%. Where did she get that number from, right? So there could be a fact check for every sentence. And that is why medical literature has so much of value, right? You can't just produce it by spending an afternoon. Now, having said that, when I started this journey, and it was basically because of patients, right? As I shared with you, I had no idea about the state of affairs with this particular problem. People were publishing this, and depending on whatever criteria they came up with, they were quoting that, 9% of our patients are experiencing weight recurrence. All the way up to 91% of their patients can be experiencing weight recurrence, because the definitions were all over the place. The criteria they used was all over the place. So they just decided a criteria. I'm going to decide if anybody gains 5 BMI points up, that's weight recurrence for me. I'm going to decide if somebody gains 20 kilograms, that's weight recurrence for me. I'm going to decide if somebody gains, it goes on and on. And that is what really bothered me, because I'm like, if we are not able to define this correctly, there is no way we can talk about management. because we are comparing apples to oranges. Your weight recurrence criteria is different than mine. Conversation ends right there.
Yeah. Yeah. Because you're not talking about the same thing. And if everybody is just picking their own definition, then it really doesn't have any meaning, right? Because it's individualized to that provider or that clinic, but it doesn't translate to the larger population of people who are fighting the disease of obesity.
Exactly. And there's no standardization, which means that we can't even talk about treatment of weight recurrence, which a lot of people experience with. And that was the whole purpose of drawing attention of the medical community. We need to address this.
Yes. Yes. And I remember when you and I first spoke about this a year and a half ago, the discussion was around, like, does this information make a difference to patients? And my immediate answer to you was absolutely 100%, because in my lived experience and in the lives of so many people that I have been a part of now, almost every single one of them experiences it. Right. But if you look at this number and you say, well, only 9%, all of a sudden you're shrinking in isolation because, oh, I'm one of the few that just, can't get it together. But it's not that number. And what I really appreciate about your research paper, and I'm just going to read it verbatim because, guys, this is in basically the intro of it. They say, so nevertheless, if weight recurrence happens, most patients retain significant health benefits compared to their preoperative status, underscoring that weight recurrence reflects the chronic nature of obesity rather than a surgical failure, right? Importantly, weight recurrence is awfully conflated with partial response and non-response. So what you've come out and said boldly is that even if patients experience weight recurrence, many of the health benefits are still existent, those metabolic benefits. But nonetheless, weight recurrence is a sign that the disease is back in action, and that requires and demands treatment.
Absolutely. I'm really glad that you have picked up on this. There are so many elements to this, April, and I hope that somebody listening to this can gain some benefit, because that's ultimately it's for patients, right? This is what this
Yes.
research is for. Number one, when patients
Yes.
see the number on the scale and they're like, oh my God, I'm coming back or getting close to the number I was at when I started this journey, they forget two things. One, time has elapsed. So let's say you're back at the same weight 5 years later. If you did not have the intervention, in this case, this is specifically focused on bariatric and metabolic surgery. If you did not have the intervention, and if you just continued with life, your weight 5 years later would be much higher than where you are at that time, in spite of weight recurrence. Let's say you lost 100 pounds with surgery, you gained all the 100 pounds back, and the whole process took 5 years. Let's just keep numbers simple. 5 years later, you would have been much more. So that's one thing people forget. We have the natural, and that's one of the things I also referenced too, is we have this data. If you look at populations as they age, men, women, anywhere in the world, the weight goes up. That's the natural prognosis or development of our weight over our lifetime. So when we gain weight, we should not be criticizing ourselves or feeling ashamed, because this is natural aging, number one. Number two, the medical comorbidities, the disease of obesity doesn't start and end with a number on the scale. That's just what's visible. That's easy to pick up. But it's so much deeper, right? Diabetes, sleep apnea, arthritis, migraines, cancer, heart disease, liver cancer. I mean, the list is so long. Your risk factor for all of these is now much less 5 years later. Even though you gained all the 100 pounds back, you are healthier at this time than you were 5 years ago, and then you would have been if you had not done something about it. These 2 points are so critical for me to, I just hope everybody understands this, because what happens is people deprive themselves of treatment. And
Mm-hmm.
I want to reach out to every single person. I say, do not hold yourself back, because you are doing a disservice to your future you by not taking this step
Mm-hmm.
right now.
Yeah.
The other
Yeah.
point I want to make sure comment is weight fluctuations. Not every pound you gain is weight recurrence. It's very normal to have fluctuations in your weight. We have it during the day. Your weight in the morning is going to be different than the weight in the afternoon. It happens. There's
Yep.
certain weight fluctuations that are normal. We don't go around weighing ourselves 5 times a day. So we don't know how our weight
Mm-hmm.
fluctuates. So when should you freak out, right? What is that number
Yeah.
for you? That should really be
Mm-hmm.
determined at your clinical follow-up, right? Between you and your clinical care team. I don't think it's fair as a clinician for me to expect that my patients do what I'm asking them to do, live their life in this crazy world, and know, is it 5 pounds? Is it 20 pounds? Is it 25? No, even this, the medical community cannot figure this weight recurrence piece out. So just keep
Yeah.
following up. Let the clinician help you figure out, is this
Yep.
plateau meaningful? Is this weight recurrence something you need to do something about? Or do you watch?
Mm-hmm. Mm-hmm. And this is the whole theme, I think, of the passion behind this weight recurrence right now, and why you can confidently say weight recurrence can be something that you avoid. Because if you are in care, right, if you are following up with your team every 3 months, every 6 months, right, every year, your clinicians, your team is going to notice that there is something happening with your weight. But you have an opportunity to say, okay, well, my weight might be creeping up, right? And once there's a definitive definition of weight recurrence, that's a tool. But it's also an opportunity for you to look at the metabolic health markers that are going on behind the scene, right? Because your A1C could be lowered, your cholesterol could be lowered. You could have all kinds of wonderful metabolic things going on that you as a patient are not giving yourself credit
Absolutely.
for. So if we're only looking right at metabolic wellness, if we're only looking at our health based on a number, we're actually missing the point of health and of metabolic and bariatric surgery, right? But as your research found, you reviewed 119 studies about weight recurrence, and only 45% of them defined what weight recurrence meant to them. There is no standardized national or international definition,
Exactly.
right?
And that is what my group has been asking, demanding, requesting, whatever you want to call it now. For gosh, we embarked this journey 10 years ago, to be really accurate. Like,
Which
it's
is
been crazy.
It's nuts.
Yeah.
It makes no sense. And I understand that I understand I guess the pushback on some clinicians to not have this conversation publicly, right? Because if you come out and you say, hey, there's a 91% chance that you're going to regain some amount of weight after surgery, people are going to go, well, why would I ever do that? But from my lived patient experience, to know that there are so many benefits beyond weight loss, right, that are here. And exactly what you said, starting treatment now means that you're gaining less weight over time. And all of the health issues that could befall you if you continue to live life without treatment are going to really bite you in the butt in the end. So this isn't a conversation about whether or not to onboard treatment. It's a conversation about how do we actually treat this disease throughout a person's lifetime, not just for this snapshot of surgery or snapshot of medication. It's a
Absolutely.
continuum.
And another thing was that the 91% is not factual, because they have not listed the criteria. So it's an opportunity for us, some clinicians, to help other
Yep.
clinicians understand
Mm-hmm.
what they are actually dealing with. And
Yes.
sometimes, a lot of the times, especially when it comes to obesity, it's not just educating the patients, it's also educating clinicians. And
Mm-hmm.
I really don't think that
Mm-hmm.
anybody is doing justice to their own ability to help patients if they don't take a step back and really reflect on what is it that I'm dealing with. What is it supposed to be called? What is the best way to manage it? You just can't throw a few things at it and the problem goes away, which I think is the way weight recurrence has been dealt with within the bariatric and metabolic surgical community, as well as the non-surgeons. And the purpose of this paper was to shed light for them as well, that, this needs to be really looked at by everyone.
Yes. And I would have a call to action for us patients that are listening and watching to this. Part of the reason that this data is all over the place is because we are not going in for our clinical follow-ups. We are not sharing our data. So the only data that's available is from the people who are actively engaged in ongoing care. But if you have ghosted your care team, if you haven't had a follow-up appointment in years, your data is not included in this, and it's desperately needed. That's what's going to give us a much more accurate picture about the true impacts and effects of metabolic and bariatric surgery and medication and all of the other treatments that we're doing, right? Because if you're going in for follow-up care and all of a sudden, right, I've regained 10 pounds, let's say, and I'm a little bit nervous about that. Well, your care team is entering that data into the database, and then they're tracking what interventions are working well for you. That is critically important data that we're not having if we, the patients, are not taking responsibility for our own follow-up care.
Thank you, April. I really, truly appreciate, as a clinician, as a surgeon and obesity medicine specialist, thank you. Because we cannot help our patients if they don't come back.
Yep. And this patient responsibility piece is something that we talk about often. And you have to take that responsibility. You have to go in and have those difficult and challenging conversations. We practice that every single day in the BariNation community, right? How can we have these difficult conversations with our providers? And the other part of that equation is if you don't trust your provider, or if you're having a difficult time communicating with them, if they're not a good fit, you have to find a person or a team that is a good fit, because there are people out there that will be the match for you. And that's, I think, where obesity treatment can really go in a different direction. If you trust your team, and if they are truly looking at you as an individual and they're treating your biology, your disease, you're going to experience results that you've never had before, because you haven't had that level of care.
Oh my God,
before.
April, 100%. I agree with you 100%. I find patients coming to me saying, what worked? What did you do that my results are different? And I'm like, nothing. There's nothing I'm doing differently other than treating it the way it should be treated. And if you don't find that right fit, you as a patient or anybody listening, need to do good to yourself. At the end of the day, I tell my patients, put your health first. Don't let an uncomfortable experience with the front desk staff, with the physician, with the surgeon, the not so great bedside manners, the insurance creating, 10 other, roadblocks, define your health and your outcome. You are better than that. You're more important than that. So you figure out a way, right? Where there's a will, there's a way. With telemedicine, I mean, the options are endless. You keep persevering to find the right fit, because once you find the right fit, then it's cruise control.
Yes, we've been having this conversation a lot this week and last week in BariNation, and the best way that I can describe my personal experience with the disease right now is I'm in a boxing ring and I'm in an active fight with obesity. I'm in like round 3, let's say. And that disease is absolutely, every punch that the disease is throwing is landing for me. But what I realize is that when I don't know what to do or how to punch back, it's my care team and it's my PCP that's standing behind me going, okay, try this. And recently it feels like my PCP is actually holding my hand and helping me punch back. And that is a very powerful way to treat this disease, because if I'm out of energy and if I'm out of gas and I can't punch, but I want to keep fighting, those are the people that are helping me do that. But if I don't have that, you're in the ring by yourself. And it feels impossible to fight this disease on your own.
I love that example. I'm going to steal that boxing ring example, April. I love it.
It's yours. No stealing. It's yours.
Thank
It is
you.
out there. We're going to pause here and say some thank yous, because without the support of Johnson & Johnson and the Texas Center for Bariatrics and Advanced Surgery, led by Dr. Joe Cribbins, this episode might not be reaching you. Their support is ensuring that these conversations find the people who need them when they need them most. A big thank you to Johnson & Johnson and Dr. Joe for your donation to the BariNation Foundation. But, you know, I think we have to lean into these visuals if we really want to connect with people, if we want to help people understand why this care is so important. And in your study, again, you very clearly called out one of the reasons that people can feel ashamed is because when you read the medical literature, right, or you just watch sometimes surgeons talking, they use the word failure.
My favorite
often,
word.
right? It comes up like the surgery failed, or right, or like patient failure, or it's failure. Well, then we adopt that language ourselves, and in our brains we go, well, I'm a failure, right? Because if I read this medical study, it says that the surgery failed or I failed. But you very clearly called that out in your research study. You're pushing back on this language. So why is it so important to remove the word failure from the care continuum? And what words are you advocating that we adopt?
Yeah, I mean, April, you've done a fantastic job deciphering this paper. And for everybody listening, April and I have not gone over this before, so I'm impressed. When people use, words matter. Words matter. You've got to pay attention to how you describe whatever you're going through, or what you think somebody else is going through. So words matter, number one. Number two, it's a reflection of knowledge. When people don't address the problem the way the problem is, it tells me that they have no clue what they're talking about. So when clinicians use the word failure, when surgeons use the word failure, I'm like, okay, just because you can cut doesn't mean you know the disease. It's the same way, just because you can prescribe a medication doesn't mean you really fully understand the disease. So if somebody really understands the chronic, relapsing, progressive nature, right? Every word matters. Chronic, relapsing, progressive nature of the disease of obesity, they're not going to use the word failure. It cannot fit in the vocabulary. If a patient is being blamed, I don't by a clinician or by front desk or a nurse, that person is no longer part of my team. Because to me, that's something I cannot fix. Right? If you're showing up to work at the Weight Loss and Wellness Center, helping patients with the disease of obesity, and you choose to use this word, that means then either you don't know, or you don't care to know, or you have a bias. And none of those explanations fit. And like in my, like the way I feel a clinical care team should be structured to address this disease or this patient population. So failure is absolutely out, and I'm really grateful and proud of the achievement of this group. The paper that you're seeing is actually our second paper. The first paper was published back in 2020, I believe, or 20. I can't remember. It's been a few years, where we then wrote letters to the major journal, medical surgical journal for obesity, saying we are officially requesting that the words failure, recidivism not be allowed in any publication. So we said we're not going to stop with just our paper. We don't want like this major journal to even accept any publication that has that word. We told all our national conferences, ASMBS, for example, adopted it, and we said no longer are the word failure and recidivism going to be part of any of our talks or our sessions. Because if you go back 10 years ago, it used to be the title of the session, and now no more. So this is a whole cultural change. And I'm super excited to be part of a community like ASMBS that got behind it and they made the change. And I haven't seen that for many years.
Wow. I think I read that in here, but to hear you say it is really powerful, because what that means is, right, that language change or that language demand can shift to the patient population. So if we're not hearing clinicians talking about, right, failure or recidivism or, failure to respond, we're hearing it in a different way. We ourselves are going to internalize that language as well, right? Out of sight, out of mind, not heard, not said. So that's a really powerful shift that is important, because again, you say, right, well, arbitrary cutoffs were frequently used to define surgical success or failure. And I'm saying this in quotes, though none were supported by outcomes data. So we're just using these words arbitrarily because, again, there is no definition, there's no matrix that we can help people find it in. And what you are advocating for is that we shift our definitions. And I'm just going to read them exactly so we're saying them right. But you're advocating for 3 different categories of weight recurrence. Can you tell us what those categories are and how you are hoping people will define them?
So the definition that we supported is a calculation which has been published for many years out of Wendy King's work. I have to give her the credit for doing that research. What my group had proposed was, this is the most thought out and relevant definition, which is a mathematical calculation, which I don't expect patients to do, but this paper is for clinicians, for us to adopt, and then use this as a criteria to drive further medical research. Then we can really say, okay, if everybody uses this definition, this calculation, we can then say the weight recurrence in your patient population versus my patient population now means something. Let's dig deeper and say, why is yours 10% and my 5%? What is it that I'm doing different? What can we learn from each other so we improve and continuously improve patient care and outcomes? That was a big thing that we needed to emphasize, is that we as physicians are students of science. We have to look at the data, which is why I'm grateful that you are asking the patients to show up, go back to your doctors, go for the follow-up, because we can't make up data. We have to go by what the patient's information looks like when they show up. The other part is, it's not just you lose all the weight and then you gain some weight back, right? Some patients respond partially. So the whole shift is, use the model of cancer. In the medical world, we look at cancer as a disease that when patients get treatment for cancer, some respond, some fully respond, and some respond partly, and some do not respond at all. So non-responders, partial response, and full response. These are the 3 categories. Now, I know nobody likes to hear the word cancer. This is just as an analogy, as an example. When you respond fully, right, you're now at a healthier weight and your medical comorbidities have improved. What worked for you? And how do we want to make sure that you stay on that path? How do you sustain that response, maintain the weight loss and the medical comorbidities? That is then the focus with that patient. So even if somebody responded 100%, right, they'd still need to come back for regular follow-up, because the focus of that follow-up should be, how do I maintain it, right? The partial response did not lose all the way. We've got to figure out what happened, right? Is it the right operation for that patient? Is it inability to really make some diet changes, because it's what you eat matters? Is it your relationship with food? Are you grazing? Are you, picking on things that your body allows to go down but are not necessarily good for your overall metabolic and bariatric. What is it? Bariatric health, what is it, right? So that's a separate focus of your clinical
Yeah.
care team. And then the non-response, their patients
Yeah.
will be like, I only lost a few pounds, or I didn't get the response that I should have gotten. That is a different category. And
Mm-hmm.
I believe, and my group believes, that the insufficient weight loss or non-response is not equal to weight recurrence. They're two totally different conditions, and they're different factors that drive it. The only way we would know this is by regular follow-up and knowing what to expect, right? When a patient comes back, I should know, my team should know, your 3 months post-op, your 6 months, your 12 months, your 24 months, where should you be? And compare it to what I believe should be your trajectory with your bariatric metabolic health specific
Yes.
to you. When I say you, doesn't mean your neighbor or your coworker, because they can be of a different ethnicity, a
Mm-hmm.
different gender, have different metabolic health profile.
Mm-hmm.
So what works for you? So South Asians need to be compared to South Asians. Caucasians need to be compared to Caucasians.
Mm-hmm.
Ethnicity, all of these specific factors matter. So the clinical care team needs to be knowledgeable enough to know what is the expected outcome, where you are today, why is there a difference, and then go after that. And again, cannot happen without follow-up. I can talk about this forever, as
Yeah.
you can see,
And
April.
that, but it's absolutely fascinating because there are so many people in our community who I think fall into that non-responder category, right? They've had surgery, they're doing everything right, but they've only lost what they consider an insignificant amount of weight. Then you have people that have lost a significant amount of weight and notice that there is some recurrence, but it's not clinically significant. And then we have, right, that partial response. So I'm reading from the research, and friends, if you download this, it's page 4, but they outline what defines partial response, non-response, and clinically significant weight recurrence. And that looks like 20% or more regain from maximum weight loss. So really you're differentiating between 3 very different experiences that people who are fighting the disease of obesity can experience. And what you're saying is that all 3 of those need a different individualized
Correct.
approach.
And their 3 are not the same. They're not equal.
Okay. No, they're
And
not
everybody
equal.
just clumps them
And
into one category, which drives me crazy.
Yes, but now we know why it drives you crazy, and it drives us crazy too. I mean, as patients, right, we think, okay, I'm going to go in and they're just going to tell me, right, to eat less and move more, which what we eat and how we move our bodies is levers that we can control along our bariatric journey. But your job with your clinician to understand what lever to pull first at what intensity, because this really is about you and how your body is responding to treatment. It's not about, right, the big aggregate data. It's you and your biology.
Well said. Well said.
It's fascinating for me because a majority of this paper is your kind of roadmap for how to treat these 3 groups differently. And what I really appreciated is I'm just going to kind of read them, right? You have post-operative clinical care recommendations. Routine post-op follow-up is number 1. It's the first thing you talk about. Then you move on to RD visits, behavioral health resources, physical activity, support group participation, right? Management recommendations for partial versus complete non-responders. And then you even break it down further, management recommendations for weight recurrence following MBS. This is really specific to what people are experiencing. And you've taken the time to clearly map out a pathway that people can take based on where they fall within those 3 categories.
Absolutely. Yeah, because this needs to be done.
Yes, it needs to be done. And I know the oncology comparison is scary, but I hate to say it, almost everybody on this planet, I think, knows somebody who has fought cancer. And they understand kind of what that looks like, right? Once that diagnosis happens and the treatment is happening, that person is connecting with their oncology team all the time. And they are checking to see how the disease is responding to that treatment option. And even if you go through treatment and it is stabilized, right, or you are in remission, you are going to follow up care 2, 3, 4 times a year, even when everything is good.
Exactly.
So this model fits obesity, right?
Yep.
Because like what you said, it's chronic, it's always present, it's chronic, it's progressive. There is no cure, there are only treatments, but as you age, the disease ages with you, and it requires that level of care.
Absolutely. On point. And that's nobody misses, no cancer patient or the family member will allow them to miss their follow-up appointment. But somehow when it comes to obesity,
Yeah,
we
no.
think of 10 other things we'd rather do than check in.
Yes, yes, yes. Well, and I'm just going to point to my own lived patient experience. This treatment pathway is arduous, it's challenging, it's difficult, and you still are fighting the disease, even when you onboard any form of treatment. But what makes that a little less arduous is having a care team by your side that understands you and your individual disease, and truly having a safe place that you can go as a patient to just say, this sucks. This is scary. I don't want to do this. I'm so frustrated. Okay, you need a safe place to say those things out loud, because once you get them out, what you can fill that void with is an actionable plan to continue to move forward and treat this disease. That's how this works.
I love it. I'm stealing so many of your phrases, April. You have no idea. I'm going to sound like April.
Excellent. Perfect. Hey, if I could sound more like you, I'd be thrilled. So we are tracking. Dr. Majid, we had a question come in from a community member, and if it's okay with you, I'd like to read her question verbatim, because I know this conversation today and what you're going to say is exactly aligned to her need. So this person says, 3 months after surgery, I stopped losing weight. Because of reactive hypoglycemia, I was put on Ozempic for a year and actually gained 7 pounds. Now I've been on Mounjaro for 4 months. I've lost a few pounds and my blood sugar is better. After 2 years, do I accept that I'm only going to have lost 35 pounds and that's it?
First of all, I'm really sorry for her to go through what she's been living through for 2 years. I mean, it's a long time. And the answer is never accept. I don't believe in accepting. I think what we need to do is really understand what we are dealing with and then adjust and come up with an individualized treatment plan that works for her. It cannot be a generic thing.
Yes.
Right? That's why clumping all outcomes of weight into one category is doing a disservice to the disease and to the patient first and foremost. So for her, I would strongly recommend that she reaches out to a clinical care team that has a true multidisciplinary model, not just a checkbox, because unfortunately, some people just provide that as a checkbox. Yes, I have a dietitian, I have a psychologist. You really need somebody who lives that embodies it, that is beyond a checkbox. And in her case, she's post-op. We need to look at her anatomy. We need to figure out if the right operation was done for the right patient, and then put all of these pieces together to come up with the tailored plan that would be best for her.
I know you offer this level of tailoring for your patients in your clinic. You have built your model really on this research, and you are working extremely hard to do exactly what you say, which is right to help people avoid weight recurrence in the first place. But it's that individual approach that you take. That's how we get different results, right? Not just a checkbox, but truly getting to know this person as a patient, then getting to know their biology, and then understanding how the disease is working in their biology and game planning from there.
Absolutely. I have learned all of this through direct patient contact, right? So 16 years of just listening to my patients, hearing them out, not being dismissive, not saying, eat less, move more, understanding what are we missing, right? And that is how I got to appreciate what we are up against, right? As a surgeon, surgery was and still is the most powerful treatment, but it didn't end there. We had a multidisciplinary, individualized treatment plan. 15 years ago. My slogan for my very first program was "Let's unite in the fight against obesity." That was before obesity was even called a disease. AMA recognized obesity as a disease in 2013. My first program was started in 2011. And that was our big slogan, "Let's unite in the fight against obesity." So I think that if you really listen and you care and you pay attention, what I'm sharing with you is not, unique. It's not something that is rare. It happens. People just either don't appreciate it or they don't know what to do with it. And that's why we published this paper, to help both clinicians as well as patients. And currently, my practice is called Weight Loss and Wellness Center. As I told you, I've had the privilege of starting 3 programs, 2 for hospitals. This one is my own practice, Weight Loss and Wellness Center. Anybody listening can go onto my website. It's very simple, weightlossandwellnesscenter.com, and you'll get a sense of what we are talking about, and happy to help anyone if they're interested.
Yeah, that is something that we spend a lot of time educating, right? The people who watch and listen to this podcast and our members. How can you find the clinician or the care team that fits you and that really is holistic? Because we can go into surgery thinking it's just about a surgery or it's just about a medication and that's it. But that is really the tip of the iceberg, right? What really has to happen in your life is under the surface, and it is expansive and it is holistic. And if you really want an integrated approach to this, right? So where you're not feeling like things are being kind of farmed out, you want it all in one place. There are questions that you can ask as a patient to really understand what system or what practice you're signing up for. But you do have to do the work. The flip side to that work, or the reward for that work, is you actually get integrated holistic care that is looking at this from every facet, not just from a single treatment pathway. Dang, this is such an important conversation. So I have some rapid fire questions that I would love to ask you. And Dr. Majid, she hasn't seen these. She doesn't know what these questions are. We are just going to go top of mind for whatever comes up. And this is going to be fun.
That's my favorite kind of question.
And I already know the answer to this first one, but I know, right? Okay, so question 1, rapid fire. Weight recurrence or weight regain? Does the word actually matter to a patient sitting in your office?
Absolutely. It should be recurrence, because it's the disease relapsing, versus regain. The connotation is you've gained the weight. And I'm really emphasizing that we need to shift the blame away from the patient and put it towards the disease. So recurrence.
Bingo. And if you have been listening or watching this whole thing, you already knew what that answer was, right? Obesity is a lifelong and chronic progressive disease. This is not a you problem, it's a disease problem. Okay. True or false? If you gain back the weight after surgery, the surgery didn't work.
False. Capital F.
Capital F. Capital F. That just means that you need to onboard additional modalities of treatment. Awesome. Okay, next question. The number one reason patients don't come back after weight recurrence?
They blame themselves and they feel ashamed.
Concurred. And the only way that we can move around that as patients is we have to power through the blame and shame. We have to acknowledge that this is a disease and that weight recurrence signals the disease is progressing.
Yeah. I would just add to that, April,
okay.
if patients just come back for regular follow-up, they don't have to get to that point of shame and blame.
Oh, now there's a mic drop moment. How we avoid that altogether is just regular follow-up that you go to.
And in fact, they can then say, I've been coming regularly. Shift the blame to the clinical care team.
Right? Well, and shift the next steps to really focus on the disease, right? What's in my control? What's not in my control? What can I do? What other adjectives, right, treatments can we onboard? Then it becomes a true team of, we're going to tackle this from all facets. Awesome. Okay, next question. Revisional surgery, second chance or last resort?
Oh my God. Revisional surgery is neither. Revisional surgery is not second chance and not last option. Revisional surgery is part of the continuum of care.
Thank you. Thank you for
Yeah.
saying that. We have a title that we bestow on our members who have revisional surgery. We call them revisionists, right? Because they are continuing to envision their life as they fight and treat the disease of obesity. So spot on, spot on.
It's part of the individualizing the treatment plan, right? So if 10 years ago you
Yes.
needed surgery X, and then 10 years later you need surgery Y, okay, this is what you need today. That's what you needed at that
Mm-hmm.
time. Why do we have to sit and justify X and Y?
Yeah. Again, it goes back to the oncology model. It doesn't matter what treatment is needed now. What matters is that we know more treatment is needed. That's
Exactly.
it. And you're gonna use anything that's at your disposal, right, to treat it.
Correct.
Yeah. Awesome. Okay. Next question. GLP-1 medications after bariatric surgery. Underused, overused, or exactly right?
I think it's exactly right. Multimodal treatment options is the way to treat this disease. Again, great analogy with cancer. We will use chemo, radiation, surgery, whatever is there, right? And there's a time and place for all of these
Yep.
treatment options. And that's the clinical care team's expertise to determine what comes first, what is combined. So we use the word adjuvant, neoadjuvant. And I think that the need to go to a place, your clinical care team needs to be an expert in all the above. They can't just be excellent surgeons and cannot handle medications or endobariatrics, or can just prescribe medications and cannot fully understand or provide the surgical treatment. The obesity care centers need to be a fully functional, comprehensive place where when you come in as a patient, you can get all treatment options under one roof. You don't have to go and start your story again and start again. I mean, who needs that?
Oh, I so appreciate you saying that. That was one of the things that came up. So I spoke on a panel at this year's ASMBS, and it was about what integrated care can look and feel like for a patient. And the number one thing that really came up for people was having to retell their
Oh my God.
story over and over and over again to new people. And they were just like, it's exhausting and it's traumatic, right? I want to say my story one time, and then I want everybody to have access to that, so I'm not going over it again. And that's exactly what you just
So,
said.
you know, when you,
Yeah.
I'm sure
It's
we all
important.
have had those experiences when you call a customer service line and you explain to the first caller
Oh my God.
for 5 minutes why you're calling, and then the person transfers you, and then they're like, wait, what? I have to start all over again? And then they transfer, and then by the fourth time I'm like, guys, don't you read each other's notes? Right? So and they're
Right.
working for the same company, and it drives me crazy. So I'm going to brag about this, because not because it's about me, it's because I want to, number one, educate the audience listening, so they can go look for those kind of clinical care models, and also help inspire, motivate, if there are any clinicians listening to this, is every single time with the three practices programs that I started, the criteria was very clear. All the patient has to do is show up. The same dietitian manages everything: medical, surgical, endobariatrics, recurrence, whatever. The same clinician
Wow.
manages it all. So I can, when I'm talking to a patient, can switch from surgery to medications to endobariatrics to divisional to adolescent, all of it in one setting. If you're not ready for it today, you're going to come back a year later, we've already have a relationship. We pull up our notes a year ago. This is what we talked about. What
Wow.
has changed, and where are
Yeah.
you today with how you feel about things? I think it is so important. I like it because I value that long-term relationship with my patients. And it gives patients confidence that, you know what, this person knows me. Like a year ago, 5 years, like whatever my challenge, whatever the reasons I decided to do one versus the other, like the example that you quoted of the patient, right? Chest surgery, Ozempic, Mounjaro. Now, I'm afraid to ask, but she probably saw multiple clinicians. So she got fragmented care. But if everything was done under one roof, then they could understand, you know, if the patient, how did the patient respond to one medication versus the other, not just extend and prolong treatment if that's not working for her.
Yep. It is a huge piece of care that often goes underrated, but it is so deeply appreciated by patients. And I think as a patient, you just have a hard time maybe really understanding or knowing that that is the kind of care that serves you best, because it does take some work to find it. But man, once you find it, it's a whole different ballgame. I mean, it is like a whole different team that is there in the ring with you. And that is worth the effort
And
to
April,
find.
it's not just about making you feel comfortable. It makes a difference in outcome. That's why I'm very passionate about it. It's not just about, oh, patients have convenience and they feel, you know, they don't have to repeat their story all over again. It's not just about that. It makes a difference in outcomes because you don't waste time. You go from one to the other smoothly, seamlessly, as long as you show up.
Oh, I didn't even think about it in that context, but you are 100% right. Wow. Last question. Finish this sentence. Weight recurrence is not a failure. It's a
biology of disease.
Oh, look at that. Biology of disease. That's exactly what this is. Dr. Majid, this conversation has been absolutely packed. And our goals for our listeners and our watchers were that we would leave here not calling regain anymore, calling it weight recurrence. We would understand that it is more common than what we think, and that follow-up care is the key to preventing it or reversing it. Do you think we accomplished those goals?
Absolutely. And I'll just add is make sure you follow up with the right team.
Yes.
Because if you don't find follow up with the right team, then patients could feel discouraged. And they're like, look, I'm showing up, but it's not enough. So showing up is number one, but showing up at the right place is number two.
Yep. Friends, I will link the research study that Dr. Majid did with her team, links to contact Dr. Majid if you would like to explore onboarding care with her. We also we've had several phenomenal conversations with Dr. Majid in the past, and I will absolutely link those in these notes as well, because we talked about a lot of similar things in this episode, and especially when it just comes to right? How we can step away from this shame and blame that we might feel ourselves and step into care is about what those previous episodes were all about. So we'll make sure that all of that information is linked there. Is there one final thought or one final thing you would like to say to the people watching and listening?
Absolutely. Obesity is a disease that you can conquer. You don't have to live with it. So make sure you don't deprive yourself with the right treatment. That is probably what makes me very upset, that some people just give up.
Yep. Well, there are reasons for that, but this conversation really helps us dispel some of those reasons, right? Weight recurrence is to be expected. You are not the outlier. It's a sign that the disease is progressing and you possibly need more treatments. And when you seek out a care team that treats it holistically and from an interdisciplinary approach, you're going to save time. You won't experience that shame and blame, and you can quickly move on to the treatment modalities that are going to work best for you.
Absolutely.
That's what this is all about. Oh, Dr. Majid, thank you so much for joining us today. This was a much needed conversation, and I'm just very excited for more people to stop calling what they're experiencing regain, to call it weight reoccurrence, and to get the treatment that they need. Thank you so much for your time.
Absolutely. Thank you.
All
It's
right.
been a pleasure.
Friends, if this resonated, share it on the platforms that you're active on and join us in the nation, in the BariNation community, if you are looking for a safe place to explore treating your disease of obesity differently. Dr. Majid, thank you. We'll see you in the nation soon, friends. If this episode helped you, help us make the next one. Become a donor at BariNation.org or click the donate link in our show notes below to join the people and organizations who keep this podcast free for anyone who needs it. Your $5 monthly gift is all it takes to amplify patient stories and spread hope to people fighting the disease of obesity. One final thank you to our donors, Johnson & Johnson and Dr. Joe Cribbins of the Texas Center for Bariatrics and Advanced Surgery, who make this show possible. We are deeply grateful for you.
Thanks for joining us. This podcast is a proud production of the BariNation Foundation, a 501c3 nonprofit.
Our mission is to advance metabolic wellness for those living with the disease of obesity by bringing you evidence-based education, stigma-free support, and meaningful connections in the exact moments that shape your daily life.
A quick reminder that the information discussed in this episode is not medical advice. Be sure to speak with your personal medical provider about your specific health needs. Thank you for listening or watching, and we'll catch you on the next episode.